So we are starting with today's Sunday class.
Okay.
Bismillahirrahmanirrahim. I am always choosing not the cases for you people. Rather, I'm trying to choose the approaches, and I'm trying my level best, even in our Sunday session, in one-to-one sessions, in courses that I try that we should be covering maximum cases through one case. So this is the same approach which we are using today, and I have chosen a case. Might be you have listened it before or practiced it before, but I will be teaching you it in a unique way, and I will try my level best that you people should have the incorporation of all the concepts. So I will try that we should be covering maximum other associated cases and presentations also. So Dr. Abdul Mateen, are you ready?
Yes.
Okay, so let's start. I am sharing my screen, and do let me know if you people are able to read it and see it clearly. So is it clear? Is it loud? Sorry, my voice is loud and screen is clear?
Yes, your voice is clear and I can read your screen.
Okay, so it is not blurred, right?
No, it's totally fine. I can see it
Okay,
clearly.
okay. So inshallah, today we will be covering our one clinical consultation approach and one clinical communication approach. With this, we are starting our session. Bismillahirrahmanirrahim. And this is the case. Have a look, see it well, then get back to us.
Should we proceed?
Yeah, for sure we can. So are you ready?
Yes.
Good. Okay, inshallah. So I am giving you the timer and your time starts now.
Hello.
Hello.
Hello. Is this Mr. Hassan?
Yes, I am Mr. Hassan.
Could you please confirm your age for me?
Yes, I am 28 years of age.
Okay. Mr. Hassan, nice to see you. Uh, my name is Dr. Abdul Mateen. I'm one of the doctors here.
Mm-hmm.
And today I'm here to talk about your health condition and to answer any of your question if you have any. Okay.
Mm-hmm.
Um, so should we proceed if it's all right
Yeah,
with
for
you?
sure.
Okay. Okay. Um, I hope I have not kept you waiting for too long.
Oh, thank you so much for your concern.
Thank you. Okay, so Mr. Hassan, could you please tell me what's going on? What have brought you to brought you here?
I am having some sort of headache, and this headache is really disturbing me a lot.
I'm so sorry to hear about that.
Mm-hmm.
Um, Mr. Hassan, could you please tell me more about your headache?
Like, what do you want to ask?
Okay, um, could you please tell me which part of your head is affected most?
Whenever I am having headache, it is all over my head.
All over your head. Okay, so it's not a specific area; it covers all of your head when you have these headaches. Okay.
Yes,
Okay. So did it develop all of a sudden or did it develop gradually?
it started quite like gradually, but it is quite aggressive one. It's progressive one when it is happening.
Okay. So it started gradually, but now it's aggressive. Okay.
Mhm.
So did it happen before as well, or is it the first time you have been experiencing this?
Like this is first time I am having this kind of headache.
Okay. So when you said that it developed gradually, so how long have you been suffering from this?
I am having it for about last almost 3 months.
So, oh, I'm sorry to hear about that. So you're having this for 3 months. Okay. So is it all the time or on and off?
It is on and off.
On and off. Okay. Okay. And could you please tell me the how does it feel?
It feels like some sort of throbbing headache.
Okay. Okay. And does it radiate anywhere, like to the jaw or any other part of your uh,
No.
okay. So anything which you've noticed might have made it worse?
No.
Anything which makes it better?
Yeah, I am going to my GP sometimes. Sometimes I'm trying with some medication, sometimes sleeping, so it is making it good.
Okay. Okay. That's good. Okay. So along with this headache, do you have any nausea or sickness?
Nausea or sickness? Ah, yes,
No. Oh,
sometimes.
okay. Sometimes. And did you throw up at any time?
No, no, only nauseating feelings.
A nauseating feeling. And is this worse in the mornings or any specific type of the day?
No, there's no any specific timings.
Okay. Okay. And was there any apart from this nausea and are your bowels all right?
What do you mean by all right?
Uh, are your bowels working fine? Like, is there any altered any change in your bowel pattern?
No,
No. Okay. And do you have any problem with the the lights when this pain starts?
no,
No. Okay. Okay. And apart from that, do you feel any dizziness?
no.
No. Any problem with vision at all?
Yeah, I am having vision problem.
Okay. Could you tell me more about that?
What do you want to ask?
So when you say that you have a problem with vision, is it just one eye or both the eyes?
Both eyes.
Both eyes. And are you bumping into things?
No.
Is it the blurring of the vision?
Yeah, you're right. This is some sort of blurring of the visions.
Okay, sorry to hear about that. Is there any tearing as well?
Tearing, no?
No. And have you felt any redness of the eye?
No.
Any possible discharge from the eye?
No.
Okay. So do you see any double vision?
Double vision. No.
No. Okay. And have you noticed that when you use the mobiles or when you try to read or write, this problem with the vision gets worse?
No, I believe that it is only there when I am having headache.
Okay. Okay. And on top of that, do you have any other medical condition?
Like, for example,
Like, have you been diagnosed with diabetes or blood pressure?
yeah, they are diagnosing me with depression and anxiety. Yeah, sometimes my blood pressure is also high. The diagnosed case which they are bothered and they are even giving me medication is depression and anxiety.
Oh, I'm sorry to hear about that. So, Mr. Hassan, could you tell me when were you diagnosed, when you were given this diagnosis?
If I am not wrong, about 1.5 year back.
1.5 year back. Okay. And are you taking any medications for that, for this particular diagnosis?
Yeah, they are giving me. Initially, I was on alprazolam, zero point 0.5 milligram at night, with fluoxetine, 20 milligrams in the morning. But
Okay.
now they have stopped alprazolam. Only I am taking fluoxetine.
Okay, I'll come to the medications again. I just wanted to ask you that how do you feel about this major this depressive episode and anxiety? Like, is it controlled now?
Sometimes I am feeling much like it is better, but yeah, not you can say you can't say that it is totally good.
Okay, so have you noticed any improvement in your mood if you compare that to your initially?
Of course, from the previously, it is better.
Okay, okay, and in terms of other, you mentioned your medications. Are you compliant with your medications?
I am a good patient. I am never missing the dosage of my medications.
That's great. That's great. So, is there any other medication which you might be taking, like over the counters?
No.
No. Okay. Okay. And have you started using any medication before the start of this these headache symptoms?
No.
No. No. And have you stopped any? You mentioned a medication which you stopped. Have you stopped it just before the onset of the headaches?
No.
No. Okay. Um, so I'll just ask you a few questions about your family history. Is there anything the same which runs in your family as well?
Yeah, my family is suffering. My father, he has been diagnosed as the case of something called brain tumor. I don't know
Mm.
exactly what is the type. My mother, she has been diagnosed as the case of tension headache. One of my sister got something called medication overuse headache. And one of my other sisters, she has been diagnosed as a case of migraine.
Okay. Okay. I'm so sorry to hear about that. Okay.
Mhm.
Um, and you mentioned alprazolam. Could you please tell me again when did you stop alprazolam exactly?
This is the old story, I believe, about 6 months back.
6 months. Okay. And currently, are you using anything for the headache?
Yeah, I am taking, like, I am only taking it when there's need for paracetamol.
Okay. Okay. And does it help when you use it?
Yeah, sometimes it is improving it, but not always. Sometimes I need to sleep.
Okay. Okay. And are you allergic to any medication or food?
Frankly speaking, I am only allergic to stupid peoples. No
Oh,
allergy with the food or medication.
okay. Okay. Uh, I'll ask you a few questions related to social life.
Mm-hmm.
Okay.
Uh-huh.
Uh, so, Mr. Hassan, do you smoke?
Yes, I am.
Okay. Could you tell me how many cigarettes and for how long?
I'm smoking, if I am not wrong, about 10 sticks per day for last almost 2 years.
For 2 years. Okay. Okay. So, Mr. Hassan, smoking is injurious to health. I would strongly advise to take steps into quitting this. And if that's all right with you, by the end of this consultation, I'll refer you to the smoking cessation clinic. Yeah. Um,
Mm-hmm.
do you drink alcohol?
No,
Sorry?
no,
No. Okay. And did you previously drink alcohol?
no.
No. Okay. Um, and what do you do for a living?
Yes, I am working as a gym instructor.
A gym instructor. Okay. And how has this thing affected your job?
It's
This headache.
quite, it is quite affecting me. Like when I am having headache and if I am there in, in the gym, it's
Uh,
difficult for me to cope up with it.
I'm sorry about that. And I have to ask you this few more related questions. Uh, I asked this to my other patients as well. Um, could you please tell me, do you do illicit drugs or party drugs?
No.
No. Okay. Okay. And do you drive to work?
No, I am having my own personal driver.
Okay. And did you travel recently before the onset of the symptoms?
I am a frequent traveler and I am delivering the live classes for the gym.
Okay. But did you travel outside the country recently?
Yeah, yeah.
And when was that?
About almost 3 months back,
3 months back. Okay. And where did you travel?
I have traveled to Africa, before that India, Pakistan, then Bangladesh, then towards Malaysia, then coming back.
Okay. And were you vaccinated, the necessary vaccination before going to Africa?
Yeah,
Okay. That's
2 minutes from now,
okay. Okay. And do you have any fevers?
no,
Any lumps and bumps over your body?
no lumps, no bumps.
Any recent change of weight?
Yeah, might be. I have lost about 2 or 3 kilograms of weight, but I believe it is negligible over 6 or 7 months.
Okay. Okay. And any spots or rash or pigmentation of your skin?
No.
No. Okay. Okay. Uh, apart from that, do you have any problem with walking?
Walking problem? No.
No. Okay. Okay. That's fine. Um, so, Mr. Hassan, I have asked you a lot of questions. Of course, I would like to proceed with the examination. Uh, so, I would like to do the examination of your nerves, which are supplied from brain to your face, and
Mm-hmm.
will be able to. After that, I will be able to comment on what's going on in terms of that. I'd
Yeah,
also
of
like.
course. Yeah, I am over here so that you should be evaluating me and checking me. No problem at all. You can proceed.
Okay, okay. So, Mr. Hassan, is there anything which you are concerned about? Is there anything which is bothering you?
Yeah, a lot of things are bothering me. Do you think that
Yeah.
this condition is totally curable?
Okay. Yeah, I can see that you're worried, and anybody in your position would feel the same way. So, based upon what I have asked you, I
I'm
think you
also
are
concerned that today my doctor has not examined me. I don't know why. Time is up.
okay.
Please summarize your case. Only positive findings.
Okay. So, Mr. Hassan, 28 years old male, he has a history of intermittent headaches all over his head for last 3 months. Um, it doesn't.
Positive,
This is,
only positive.
yeah, this is associated with the blurred vision, but no other. This is associated with blurred vision and a previous history of major depressive disorder and anxiety, for which he was taking fluoxetine and stopped alprazolam 6 months before. Uh, there is he uses with good effect the paracetamol. Based upon the history, I believe that and his blood pressure is also 160 with a positive family history. So based upon the history, I would suggest that this might be a tension headache, or the my second most important differential would be medication overuse headache, because he is having a lot of paracetamol, so that might have been resulting in the headaches.
Okay, continue telling me your DDs, and all the listeners should write down the appropriate differential diagnosis, even though there's a limited information extracted by Dr. Abdul Mateen. Try to give your DDs in the Zoom chat box. I am seeing your messages. Please go ahead.
Okay,
Yes,
and
Dr. Abdul Mateen, any other DDs?
my next DD would be considering the blurring of vision, glioblastoma, and there is a family history of brain tumor as well. So that would be my third differential, and my fourth differential would be raised intracranial pressure, considering the blurring of the vision and
Your
considering the whole.
brothers and sisters are posting some DDs to me and they are not agreeing with you. I'm getting the messages. They are saying a lot of other DDs. So, do you want to consider any other thing? Hmm.
There is a history of going to Africa, but he was vaccinated, so I'm not very much bothered about that.
Okay. So, people are writing some DDs. I'll be discussing them later on because right now we are in the exam condition. So, Dr. Abdul Mateen, what is your first diagnosis?
Uh, Tension headache.
Tension headache. So, considering it a case of tension headache, so are you asking about any mood changes recently associated with the headache?
Uh, I did ask about the mood
Okay,
changes, which
might be generalized anxiety disorder. Okay, might be. Considering it a case of a tension headache, so do you think that the blurring of the vision is a common feature of this type of headache?
no.
Okay, so considering it a case of tension headache, are you evaluating body aches and fatigue?
No, I didn't.
Considering your DDs, are you evaluating the blood pressure of 160 by 100? Okay. What is the second DD?
Yeah, so yeah, this could be very well be. My second DD was I've not written it. Glioblastoma, considering the family history.
Glioblastoma. Glioblastoma will giving you which sort of headache? What do you think?
So most of the times this is early morning.
Early morning headache with the coughing, with the sneezing, with the bending forward, with the vomiting, with the focal neurological deficits. Are we getting anything in this case?
just the blurred vision, and yeah,
Okay. What is your third diagnosis?
it was medication overuse headache.
Medication overuse headache will not give us blurring of the vision.
Uh,
will not give us all these features. And also, you are not evaluating exactly how much paracetamol he is using per week and for how long. It
Yeah.
has its strict criteria to label it as medication overuse headache. Okay, so considering your DDs, how you will be formulating a good management plan for this patient?
And the other one would be high blood pressure can also cause the headaches as well.
So, high blood pressure induced headache, what it is called? Mhm. Okay. So
Yeah.
please constitute your good investigation plan for this patient.
So I would like to proceed with uh, the baseline blood tests, and I would also like to proceed with a scan of the head. MRI brain would be the investigation of choice.
Okay. What else?
First of all, I would have to complete the examination, which I was not able to. After that, all this blood test, after that, the scanning of the brain, and I will be guided by the results of the scans of the brain for further evaluation of the patient.
Any management options for your patient?
Uh, so acutely, I will give this patient analgesics. I'll start with paracetamol, and after the results of the
Okay,
investigation.
considering this patient as having medication overuse headache, so how you will be treating it? This is not a medication overuse headache, but say, for example, you are considering it as a medication overuse headache, and this patient presented to you in your ER with the headache. What you will do now?
So in medication overuse headache, first of all, I would sit with patient and explain to him that this is the situation.
No,
And
you are saying acute setting, ER setting, acute setting.
yeah, so first of all, I would have to advise him to withdraw his medications.
That's
And
what I wanted to point out. You were saying that I will be giving painkillers. Okay. So it
yeah,
means that our DDs are getting contradicted with our management. Okay.
yeah,
Any other management option for Mr. Hassan?
yeah, it will be, I would be guided by the investigations after this.
Okay, let's discuss this case. Okay.
Okay.
Let's start. My screen is clear to you? Are you able to see my screen, please?
Yeah, yes, I am.
Okay. So please kindly keep your mic unmuted.
Okay.
So we are having a discussion on this case.
Sorry.
I am saying we are starting discussion on this case.
Okay. Okay.
Bismillahirrahmanirrahim. Basically, this case, I will say that this is a prototype case. How it is prototype case, let's discuss it over there. So before we are going ahead and before we are exploring this case, when we are entering the examination hall, first thing which is bothering me a lot, this guy is only 28 years of age. He is known case of depression and anxiety. My patient presented to me PC presenting complaint that is number one headache, and they are categorically telling me that this is off and on with the fatigue, with the body aches. Are you with me?
Yes.
Moreover, I am seeing that the patient blood pressure is on the higher side. This is all about summary of this case. this case. This is what they are giving us, except mildly raised ESR. Now, the thing which we want to do over there is that we should be taking into account all these issues. Rather, this is the issue list. Now, before you want to start it, you want to start it from the headache. So no problem, start it from the headache. Okay. So in the headache, this is a pain symptom. So we are going towards your friend called Socrates. As for exact site, you are asking onset. When it is starting, because it is coming in the episode gradual or gradual or sudden, then character, how it feels like. You're asking everything, I'm just repeating. Then radiation, is it going to any side? Associated symptom, A for associated symptoms, I am skipping for now. T for timing, any special or specific timings, because your friend raised ICP headache and OSA headache is happening in the morning. Then exacerbating relieving factor, what can be associated with the headache in regard to exacerbating factor? It can be coughing, it can be sneezing, it can be bending forward, it can be changing in the posture. Are you with me?
Yes.
Good. Relieving factor might be some medication, changing in posture, some environment, something like that. Then severity, there's a lot of difference if this headache is 5 out of 10 or 10 out of 10. Before I'm going toward the associated symptoms, let me explain more these symptoms, because I promise you that inshallah I will be covering multiple cases through one approach. Sight. If this is right-sided headache or left-sided headache, so multiple things are coming in my mind. It can be migraine, it can be cluster headache, it can be giant cell arteritis, it can be attack of acute congestive glaucoma, even with the facial pain, it can be trigeminal neuralgia. But if you are exploring one-sided headache in more detail, migraine or even acute congestive glaucoma attack or the cluster headache, these type of headaches will be recurrent. Joint arthritis will happen only once, or first presentation. So
Yeah.
presentation of the headache, site of the headache matters a lot. If it is whole head headache, so it might be tension headache, it might be medication overuse headache, it might be any headache even as well. Getting back to the severity, if it is 5 or 6, I can say it might be something called tension headache, it might be medication overuse headache. If it is very severe, say for example, patient is saying 9 out of 10, so I will be considering subarachnoid hemorrhage. I will be considering my migraine will be moderate. I will be considering joint arthritis. I will be considering cluster headache. So each and every point in the Socrates is golden towards your diagnosis. Are you getting me?
Yes.
Good. Now let's go ahead and say, for example, character. Tension headache, medication overuse headache, they will be dull, boring. Cluster headache will be very sharp. Migraine will be throbbing type of headache. Are you getting me?
Yeah.
So each and every point when you are asking it, you are not asking for the examiner. You are not asking for the patient. You are asking to pave your path towards the success or diagnosis. Getting back to the associated symptoms, so you have to speak louder. What can be associated with the headache? Go ahead, I'm waiting.
It's vomiting,
Vomiting, making sense.
dizziness, blurred vision,
Dizziness,
blurred vision, focal neurological signs.
Blurred vision, focal neurological deficits, making sense, but I need more explanation of it. I'll be explaining. What else?
Seizures
Fitting episode, good.
and blackouts
Blackouts, okay, good.
and just like blurred vision, this double vision could also be one of the.
Hmm.
And there could be
Double
gastro.
vision, bumping into objects, what else?
There could be spots in front of eyes.
Spots, you mean to say aura.
Aura.
Aura symptom, making sense. What else?
Uh, there could be
Can it be altered sensorium? Can it
yes,
be fever? Can it be weight loss?
yes,
Just a second, please. Okay, so in these symptoms, how many we are getting? We are getting nauseating feelings, we are getting blurring of the vision, we are getting. You are not asking, but altered sensorium also was there. Okay.
okay,
Now, before labeling or considering or getting, convinced that this blurring of the vision or any other symptom is continuous, I must ask the patient, is it associated with your headache or not? Assumptions are the killer in the PACES. Yeah, it is associated. These symptoms are associated with the headache. So what I am getting that whenever my patient is having episode of headache, he is having sometimes altered sensorium, blurred vision, nausea. So how to ask about altered sensorium? You can ask increased sleepiness. You can ask about disorientation. Disorientation is English word. Clear?
yes,
Now, keeping it in mind that this headache is happening in the episode with these symptoms, so I should be asking myself what it can be: nausea, blurred vision, altered sensorium, meningitis. No, it will be not be there for the 3 months. Symptom will not be coming and going. Okay.
yeah,
Brain tumor. If it is brain tumor, why I'm not getting any vomiting, early morning headache, coughing, sneezing, bending forward, making it bad, and why this headache is getting better in between? Is it
yeah,
medication over your headache? Not making sense. Is it tension headache? Might be, but blurring of the vision, altered sensorium, I can't explain. This is the art of making DD. For me, something bad is happening. Patient is having headache, nausea, blurred vision, altered sensorium, then getting improved. Up till now, what is making sense in my mind, I am not telling you. I will be telling you later on so that you people should have some mind storming. Now, after that, the second issue over there is the issue of fatigue. My voice is getting a lot to people.
yes,
For me, fatigue has different meaning. For you, fatigue has different meaning. For patient, fatigue has a different meaning. My postgraduate residents are saying that, sir, we are stressed out. Or say, for example, we are tired. A doctor is saying I'm tired. Different meanings. I am saying to my wife that today I'm very fatigued out. Different meanings. Patient is saying that I am fatigued out. Different meanings. A patient with a cancer is saying I am fatigued out. Different meanings. Patient with chronic Anemia is saying I'm fatigued out, different meanings. Fatigue is a symptom which need explanation, with the need proper meanings in each part of the word. Are you getting me?
Yes.
So again, Odipara, onset, yeah, it started quite gradually. Duration, almost I'm having it for the last 6 months. Relieving factor, nothing is relieving it. Aggravating factor, nothing is aggravating it. Associated symptoms. So I think we have discussed it before also, but I'm repeating for you people because repetition is making your mind clear. So what can be associated with the fatigue? So I am going just a second, head to toe. In the head, it can be diabetes mellitus, diabetes insipidus, polyuria, polydipsia. In the head, it might be some tumor making sense, but we have ruled it out. Coming down, slightly coming down in the eyes, it can be anemia symptom, fatigue associated with anemia. Coming down, there's your friend thyroid. It might be the symptoms of hypothyroidism. Are you getting me?
Yes.
Coming down, there's your friend called heart. Symptoms of heart failure. Coming down might be something linked with the CA lung. Just you can ask one or two questions. Excessive weight loss with the coughing up of blood. Coming down, there's your friend liver. Remember PBC, PSC sisters?
Yeah.
Remember hepatitis? So what you should be asking?
So in terms of liver, we'll be asking jaundice. Yeah.
Maximum itching. Coming down, I will be very interested in the fatigue to ask about your friend. Chronic diarrhea. Coming down, this fatigue might be a feature of something called, tell me, connective tissue disorders.
Connective tissues.
Joint pain, skin bruising. Clear?
Yeah.
Now, getting back, I am not getting any specific feature in this patient. Clear, just the fatigue. Finish. Body aches, what it can be? First ask the patient, what do you mean by body ache? Then localize it. Exactly where is the body aches? So I am body aches can be the feature of your friend hypercalcemia. That is, tell me, bony pains,
Bony pains.
deep-seated body pains, severe pains. It can be feature of hypokalemia, muscle pains. It can be feature of, sorry, just a second. They can even attribute body aches to joint pains, separated. So when you are taking a short history, it is also the symptom which is there for last 6 months. It means that the story started 6 months back, but the patient right now is presenting with the headache, and this headache is there off and on and off, or off and on for last 3 months. Is it clear?
Yes.
This is the complete summary. Fatigue, body ache, body ache 6 months. Headache off and on with a blurred vision, nausea, sometimes altered sensorium for the last 3 months. Clear?
Yes.
Diagnosis not in hand, no problem. Get back over here. Problem list. There's your friend called high blood pressure. Whenever you are dealing with high blood pressure, make it very sure that you should be asking few questions to yourself.
Yeah.
Number one, is it white coat? Read what I'm writing.
So, is it white coat? Um, is it true hypertension? Any complication?
Any
Like,
complicate? Is it true? Is it white coat hypertension? Is it true hypertension? Any complication present? If young, what is the etiology? Without answering these questions, especially in a young age, my candidate will not skip high blood pressure because this thing is bothering me a lot over there. This is my stress or this is my challenge.
yeah,
Are you getting me?
yeah,
So, are you having high blood pressure? Are you aware? Answer can be I am having high blood pressure every time I am visiting your office. Okay. Are you ever checking at home? No, I'm never checking it at home. It can be white coat hypertension, so I will be offering ambulatory blood pressure monitoring. Clear?
yeah,
It might not be white coat hypertension. So yeah, I am checking it at home and it is also coming on the higher side. There is something fishy. Clear?
yeah,
So it is true hypertension. Complications? I am getting back in the end. Getting back to etiology. Just a second. Are you able to see my screen?
yes,
These are the causes of secondary hypertension with the mnemonic triple A, double B, triple C, double D, E. And I have shared multiple times in the courses. This is repetition. So it is very easy for you. And it will really not take more than 20 or 25 seconds to exclude these causes. Patient is very fatty, increased BMI. I will be considering OSA with a history of snoring. Acromegaly, it will be evident in front of me with a broad hand, broad feet, frontal bossing, progonatism, interdental spaces. Yes, if you want to make sure, you can ask about bumping into objects with the frontal, not complete frontal headache.
yeah,
Excluded, it can be
yeah,
renal bruit, renal artery stenosis. But unfortunately, it will not be giving any specific history. Getting back to baby pregnancy, of course, the patient is male. Cushing, ask about diabetes, ask about proximal weakness, ask about bruises on the skin, ask about striae on the tummy, ask about any steroid usage, ask about poor wound healing. Nothing there. Catecholamine excess. These questions of catecholamine excess should be on your fingertips. Any racing and pacing of heart with this headache. Any excessive sweating with this headache. Any tremors, shakiness of the hand with this headache. Any flushing of the face with this headache. No, your friend, the pheochromocytoma gone. Coarctation of aorta, difference in the blood pressure between two arms, difficult to elicited the history. So better is that it should be checked in the examination. Any drugs which you are taking, including prescription drugs, over the counter medication, or illicit medication, including one thing in this patient, in this profession, what? Think, Dr. Abdul Mateen.
Sorry, in
Gym
this,
supplements, gym
yeah,
supplements,
supplement.
gym supplements. Then diet and erythropoietin excess will be with your friend renal cell carcinoma presenting with weight loss, hematuria, loin pain.
Yeah.
I am not getting single history in this yellow card. Okay, I'm fighting back for my case.
Yeah.
Patient is having high blood pressure. Patient is young. Patient is having severe body aches, fatigue, what it can
Yeah.
be.
It can be drugs, corticosteroids.
No drug history, no corticosteroid history, no steroid history, no any illicit drug history. Body aches, fatigue, hypertension. Okay, let me define. Hypertension with hypokalemia. Because body ache, fatigue are the features of hypokalemia. Cone syndrome, aldosteronism, hyperaldosteronism. Are you getting me?
Yes.
So diagnosis in my hand. If you want to approach headache, number one, this chart, another chart I am showing you people, incorporate it in your neurons. Don't cram it. Don't do ratification. Absorb it in your neurons. Inshallah, you will not miss any secondary cause of hypertension. And when to exclude it? When we are getting this hypertension in young age patient. Clear?
Yes.
Good. Now things are not, you can say, getting, you can say getting closer. Okay, I agree. Patient is having high blood pressure. Patient is having fatigue. Patient is having bad body aches, making sense that it can be Cone syndrome. But why the patient is having headache off and on with altered sensorium, with nausea, with blurring of the vision? Any explanation? He's reading a book
Mm.
in the room, having bad headache, nausea, blurring of the vision, and sometime, not always, sometime tending to get disoriented. What it can be? Hypertensive emergency.
Yeah.
Clear?
Yes.
So in the background of Cone syndrome, my patient is having these acute problem with the hypertension, which can be hypertensive urgency without end organ damage, or hypertensive emergency with end organ damage like piloedema, like something called hypertensive encephalopathy altered sensorium, like renal shutdown, acute renal shutdown. Are you getting me?
Yes.
Good. So we are, bringing the blocks together. What happens that sometimes the candidate is having a very good history, but unfortunately, he or she is unable to bring the blocks together. So separate every symptom, then join them together. And only you will be able to do only when you are making this, sorry, when you are making this list outside examination hall. Clear?
Yeah.
Good. So diagnosis in my hand. Not only diagnosis in my hand, rather I'm confident that I have ruled out pheochromocytoma. I have ruled out Cushing. I have ruled out acromegaly. I have ruled out multiple other things leading to secondary hypertension. And second mistake, I want to stop over there for a couple of seconds. That one mistake you are making, Dr. Abdul Mateen, this is quite concerning for me. That is, uh, if you are taking the history in a very fast way, take my words, and Alhamdulillah, my candidates are doing it. You will be able to finish your history in max 8 or 9 minutes. But if we are taking the history in this fashion, Dr. Abdul Mateen, from which
Yeah.
country you are? I am from United Kingdom, Dr. Salman. Okay, you are from United Kingdom. It will waste my time.
Okay.
Clear? Dr. Mateen, what are your hobbies? Dr. Salman, I like to play cricket. I like to go to gym, long drives. Okay, you like to play cricket, going to gyms, long drives. This is killing the time. They will not give me extra marks for it. Dr. Mateen, what are your hobbies? I like to play cricket, gym, and long drives. Okay. So, Dr. Mateen, can you please tell me about your country? Yeah, that's Salman. I'm living in the United Kingdom. Okay. Okay is enough. Is enough. If we are repeating the same sentence, it is doubling the conversation. Are you getting me?
Yes.
And there was doubling in your history taking. Okay.
Yeah.
So try to deliver your questions, fire the questions fastly. And we will be able to do it when the questions are on our fingertips, when the approach is on our fingertips, how to grasp hypertension, how to take over hypertension in a young age patient. Secondly, when we are not doing any repetition. Yeah, say for example, sometime candidates are saying, I feel sorry that you're having headache. One time is okay. No need to again say that I'm sorry you are having this, I'm sorry you're having this, it's killing the time. No extra marks will be given. Getting back to this case, so this patient is likely having hypertensive emergencies with Cohen syndrome. Last challenge over there for me was, which I was skipping deliberately over there, is complications. Sir, you ever got any stroke? Ever got any bad severe chest pain? Have you ever felt that there's decrease or increase in the waterworks with the foam there? CKD. Do you feel ever the pain on walking? Peripheral arterial disease. Enough. Finish. Story finished. Clear?
Yes.
So when my candidate is approaching hypertension in a young age patient, he or she will always, number one, check etiology. Rather, before etiology, confirm that is it a white coat hypertension or true hypertension. Question is, are you checking it outside healthcare setting? Yeah, I'm checking it on the higher side. Okay. If not, then you have to offer ambulatory blood pressure monitoring. Secondly, what is the etiology of this hypertension? Thirdly, any complications if we are having. Lastly, if say for example headache was not a presenting complaint over there, even in the elderly patient, always exclude hypertensive emergencies. Just one or two questions. Number one question is, do you feel that you're having bad headache with the dizziness or some sort of disorientation? Along with that, some blurring of the vision, along with that, some vomiting, nausea, or might be having absent urinary output. Finish. You are getting this history or not? It's another thing. But at least you are doing a safety netting that you are excluding it. Clear?
Yes.
So this is a set pattern in any hypertensive patient who is coming in the young age. Now ask your general questions: fevers, lumps and bumps, weight changes, rash, spots, pigmentation, diet, appetite, sleep. Then of course weather preferences, of course hyperthyroidism you will be excluding out. Then And you can ask about any tremors or sweatings. We have the questions which we have already asked. We will not repeat them again. Make it very crystal clear and sure, because number one, it is not making good sense. Secondly, it is also killing the time. Then, of course, past history. Have you been diagnosed with any condition in the past? I am having depression, anxiety. Are you in the regular follow up? Yes, I am in the regular follow up. Whenever you are feeling depression, always exclude one thing, that is suicidal ideation. Sir, I want to ask you a personal question. I'm not getting judgmental. I hope you will not mind. Do you ever try to end up your life, or this thought is coming? So at least you're doing safety netting to exclude suicide, because if there is the risk for suicide, so you have to restrain the patient under Mental Health Act Section 5(2). Are you getting me?
Yes.
Good. Then allergies, then medication history. Medication history was very beautiful by you. I will not repeat it. You have done it very well. And I think you have completed all the points in it. Then family history, then social history, smoking content past, alcohol content past, illicit drug, driving, traveling, of course, driving, traveling. Sajid loves tea. Smoking, alcohol, job, history, driving, traveling. Yes. Now we have asked multiple symptoms, but still, if you feel that you might be missing something, so you can ask in the systemic inquiry, and the systemic inquiry must not be more than 30 seconds. Now, sir, I want to ask you, if you check this question, just reply me in yes or no. Clear?
Yeah.
Everything smooth?
Yeah.
In the summary, we started from the headache, we have done the Socrates, then we have evaluated fatigue, then we have evaluated body aches, then we were bothered about high blood pressure, and then the general questions, ultimately past history. We excluded suicidal ideation, allergies, medication history taken very nicely by you, then family history, then Sajid loves tea, smoking, alcohol, job, illicit drug, driving, traveling. Last is systemic inquiry if you want to ask few questions. Now, examination. Examination should be very tailored. It should not be random. If we are randomly doing the examination, we will lose marks. Sorry, not lose marks, we will lose time. So I am sharing a scheme for you. Are you seeing it?
Yes.
Like, is it readable? Like, are you people able to read it, or too small font?
Yeah, it's fine. It's readable.
Are you sure? Should I
Yeah.
expand it? No, 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 it will go away because this
No, it's
chart was
fine.
quite lengthy.
I can read it clearly.
Okay, okay, just a second. Okay, so we are starting examination. Now, in the Crohn syndrome, so we are making our already diagnosis that we are dealing with Crohn syndrome based on our history. But again, I am bothered about a few other findings. Now, first, offer examiner the observation charts. Second thing which I am really bothered is to check for blood pressure. And after checking for the blood pressure, I can go for adrenal gland examination by palpation, renal masses. So you can do by kidney ballotment, kidney ballotment by sorry, what we say it as, by manually. Clear?
Yeah.
Now, see how to approach this case. We need to rule out renal artery stenosis. So we will be checking the renal bruit. So where to check the renal bruit? You will be checking on the both sides lateral to the umbilicus, renal bruit.
Yeah.
Second, coarctation of aorta. There will be difference in the blood pressure in each arm with radial delay. Hyperthyroidism. You can get sweating on the palms. tremors, might be some neck lump with proptosis. Then, getting back to pheochromocytoma, already we have checked for the abdomen, and then we are checking for tremors and sweatings. Now, getting back to Cushing, proximal myopathy, bruises, then buffalo hump, moon-shaped face, then of course try on the tummy. If it might be a case of OSA, so I am offering a neck size. Neck size should be more than 16 or 17 inches label at OSA. Are you getting me?
Yes.
Forget about this chart. If you are thinking this is complex, I was not reading this chart when I was speaking. I was keeping in mind this chart. Only
Yeah.
remember this chart if you want to be have a easy approach in the hypertension. This chart is only, say for example, if you want to have a theoretical approach. But I am always considering this chart not only in the PACES or basic teaching, on also in my routine OPDs. So apnea making sense, patient will be having increased BMI with the snoring history, of course, examination. So of course, increased neck size. And if there is increased neck size, so it is mandatory for me to rule out your friend called cor pulmonale. How shifted apex beat, how left pasternal heave, how raised GVP, how pedal edema. Clear?
Yeah.
Con syndrome, bimanual kidney palpation. Acromegaly, self-explanatory. We have discussed the findings, and it is a complete different case. I'm not going in the detail of its examination. Brui discussed. So Cushing discussed. Common sense. There's no rocket science in it. Then, of course, pheochromocytoma. What you have to check? Pulse, tremors, sweatings, facial flushing, bimanual kidney palpation. What else you want to check? Maximum complete abdominal palpation. Coarctation of aorta, pulses, delays, and then corticosteroids. Check. Already we have checked for proximal myopathy and all that stuff of linked with the corticosteroids. RCC, we have already bimanually palpated the kidneys. Is it clear? Easy?
Yes.
Good.
It makes sense.
Good. Thank you. Now, time is left. No problem. Check for peripheral pulses. If there is blurring of the vision, if and is present right now, it will be a crime not to offer fundoscopy in this patient. But say, for example, this is a long-standing hypertension and you are having time, ample time, so you will be offering fundoscopy to check for hypertensive changes in the fundoscopy. And we have discussed all these changes in the last session, much detail with the help of audiovisual support. Clear?
Yeah.
Good. Now, if the patient is saying that I am having heart failure signs also, and we ask them with the fatigue, remember? Orthopnea,
Yes.
PND, pedal edema, go for
Present.
checking for S3 and go for checking for biphasic capitation. If no symptoms there, it will be, I believe that wastage of time. We should be saving the time for the concerns. Clear?
Yes.
So uh, sorry. So we have done our history examination, and even we have answered the concerns. Concerns should be answered in very swift way. Now, what can be the dealings? For me, likely this is a case of hypertensive emergency in Cone syndrome. Second, it might be hypertensive emergency in the Cone syndrome. Third, it might be hypertensive retinopathy with the Cone syndrome. For that, if I'm making this DD, need to do fundoscopy. Down the list, I am very interested to check for Liddle syndrome, similar presentation, very similar. Of course, I am very interested to say to my examiner that I am very interested to rule out pheochromocytoma and relevant secondary causes. Clear?
Yeah.
Good. Okay, so let's get back to this case. Now we need to formulate our investigation plan. Again, investigation plan should be very logical. If you are having no logic behind each investigation, kindly don't offer to examiner. Why? Because if he's asking why this investigation, we will not be having the answer of why. So imagine, let's formulate a plan for this patient for investigations of this hypertension. Sorry, one thing I want to mention, I think I have forgotten that if the patient is having hypertensive emergencies, so you will be getting in the eyes, tell me, in the fundus. Mm-hmm.
Cotton wool,
Below edema,
papilloedema. Yep.
blurred disc margin with the swollen disc. Blurred disc margin with the swollen disc. I am categorically speaking two words. Blurred disc margin with the swollen disc. Why? Because sometimes the candidates are confusing it with optic neuritis, in which the disc margin are blurred but not swollen. Good. Now investigations should be in a way that we should be doing it. So number one is you are, of course, going for aldosterone renin ratio. So it is on the higher side. So aldosterone is quite higher, quite higher. Why? Because it's hyper aldosteronism. It is secreted by some adenoma or something like that. So it is hyper. So aldosterone is hyper and it is suppressing the renin. Why and how? Because of the negative feedback. So aldosterone is high, renin will be low, so ratio will be up, increased. So usually it is even more than 20 or 30. Clear?
Yep.
Good. Now, what aldosterone is doing? It is reabsorbing what? Tell
Salt,
me.
sodium.
Sodium. So you are giving oral sodium diet, high sodium diet for at least 3 days. Taken it, salty diets, followed by 24 hours urinary collection. So now you will find that this will be on the higher side. Urinary aldosteronism. This high sodium is not suppressing it. I think I am, just a second. Aldosterone, just a second. I'm having mental block. Secreting, I think. Now, sometime, this is happening and it should not happen, in the exam. So what I am, or if we are giving the sodium diet, yeah, it is reabsorbing. It is reabsorbing sodium. Yeah, it will be suppressing the aldosteronism, but the negative feedback, but it is not suppressed. So you will be getting after the high rich meals of the sodium that there is increased sodium increased aldosteronism in the urine. Clear?
Yeah.
Now, what else? What we have to do? We have to go for imaging, making sense. So imaging, we are going for CT, or might be we are going for MRI. Why? You want to locate your friend called adenoma. There is another test which is gold standard, but it is invasive test. So we have to do adrenal venous sampling. Then, of course, basic test, serum electrolytes. So what will happen if aldosteronism is there or aldosteronism is high? So there will be hypokalemia because it is secreted outside the kidney. It will be reabsorption of the sodium leading to hypernatremia. So patient will be having hypernatremia with hypokalemia. Now, after that, what is left? Lots of things are left. I am really bothered about ECG. I am really bothered about left ventricular hypertrophy echocardiography. I am really bothered about renal function test. I am really bothered about urinary urine for protein. Clear?
Yes.
Now, still, if diagnosis is in question, we need to rule out other DDs also. What we are doing, we are going for urinary metanephritis. We are going for urinary VMA. We are going for urinary catecholamines, serum catecholamines. Clear?
Yep.
Good. Now, let's go ahead. There's one question. I am liking this question in the Zoom chat box, that but the BP is 160 by 100, emergency is much higher. Am I right? You are very right. Right now, the patient is not having headache. Headache is a history off and on. Right now, your patient is stable. Right now, he is not having hypertensive emergency. And I don't believe that they will be giving you patient with hypertensive emergency in the real exam. So what I want to say is that they are telling you that there's a history consistently for the last 3 months of off and on high blood, of off and on headache. And right now, the BP is 160 by 100. So this is the point what I want to explain. Okay, so there are also some questions in the Zoom chat box. I'm sorry, I'm concentrating right on the session, so I will be doing the questions session at the end. Now, going back to this case, actually, this is interrupting, the flow. Now, going back to this case, so we are now having our management. So in the management, first thing is patient education, making sense? Patient
Yes.
counseling. Then you have to tell the counsel about these attacks of emergencies. You have to counsel about the hazards of hypertension. You have to counsel for the diet. Which diet? It is making sense. Low sodium diet. Clear?
Yeah.
Then what else? We are quite concerned about blockers. That is aldosterone antagonists. Spironolactone.
Yeah.
Usually it is first line. Then a new drug, eplerenone.
No.
If still not managed, you are free to add any other antihypertensive like thiazide diuretic, like calcium channel blocker. Make sure you're keeping eyes on the sodium and potassium. If still not managed, you can add any other antihypertensive according to the guidelines. Nice guideline. Now, usually there is adenoma. So what is the management? You have to remove the adenoma specifically, or you can say preferably through laparoscopy approach. Clear, Dr. Abdul Mateen?
Yes, it's clear.
Good. So I think we should be going towards our clinical communication station. Then we will be having question answer session. Thank you so much, Dr. Mateen, for your active participation, your time, your participation, your history, your skills. Inshallah, we'll be discussing it later on. Okay.
Thank you.
So yeah, welcome. So let's go ahead towards Dr. Olina. Dr. Olina, are you with me? If you are with me, please use the raise hand option to come forward. Dr. Olina. Dr. Olina, we are waiting for you. If you are listening to me, please use the raise hand option. The option is given over there in the Zoom chat box, near the Zoom chat box. You can use it, you can come forward, and I will be unmuting you. Okay. Dr. Olina, please unmute yourself.
Hello.
Hello, Dr. Olina, how are you?
Good, thank you. How are you?
Yeah, I am fine too. So, are you ready for your clinical communication?
Yes.
Your voice is slightly low.
Hmm.
Can you bring your mouthpiece closer to your mouth?
Uh, I'm trying. Is it better now?
I think it is better now, so we can have a testing. So, how's your PACES preparation going on?
Um, Slow.
Slow. Okay. Inshallah, it will be fast. Don't worry. Okay. So, I think this is better now. So, we are starting our clinical communication. And this is slightly a lengthy scenario. So this is a technical scenario. Please try to tell me exactly, are you people able to read it clearly? Just a second. Why the file is not being opened? Okay, now see, scenario is readable or not.
Yes,
Are
it
you able
is
to read
readable.
it? Okay,
Yes.
good. Take your time.
Yes, I've read it.
Dr. Olina, once you're ready, please do let me know.
I am ready.
Okay. If you need more time, no problem at all. Tell me.
Yes, yes, I am ready.
Okay. I am giving you timer, and your time starts now.
Hello, good afternoon. Is it Mr. Shuja?
I am Mr. Shuja.
Nice to meet you, Mr. Shuja. My name is Elena. I am one of the doctors. I presume you are the father of Asif?
Yeah, I am the father of Mr. Asif, 18 years old boy.
Nice to meet you.
Very
So
nice to meet you too.
tell me please, how can I help you?
I don't know what's wrong, but yeah, I got a call from your hospital that your son is not doing well and you should be coming to the hospital. And I am coming to the hospital. And I was listening to the two staff nurses talking that he was having a very bad fitting episode. So I'm quite surprised that we're having no family history of any sort of sorry, any epilepsy or something like that. Like why he is having this fitting episode, how he's doing now.
I see. So I'm pleased to tell you that he's doing well right now. But yeah, you're right. A few days ago, he had been admitted with the seizures, and um, it was actually quite severe that uh, we had to paralyze him, and we had to put the tube down his throat and had to intubate him. But luckily, he is doing much better now. The tube is
I'm a
taking out,
poor
and
motor mechanic. I'm not educated a lot. What do you mean by intubation?
we had to put the tube down into his throat to help him breathing.
Okay.
And
I believe that he was quite critical.
yes, he was quite unwell, but he's doing much better now. We had taken the tube out, and he is now awake. He is now completely fine. He is talking, he is alert, and he is able to speak to you when you wish to.
Mm-hmm.
And yeah, there is absolutely no consequences of this episode at this point.
Mm-hmm.
There are multiple reasons why people might be having seizures or fits. As you
Mm-hmm.
said, you have absolutely no family history. Nobody in the family had anything like this before. Is it correct?
Mm-hmm. Mm-hmm.
Um, some people can have something that is called epilepsy,
Mm-hmm.
and it is not necessarily happening in as a
Mm-hmm.
something that is inherited from the family.
Mm-hmm.
Sometimes it is happening because people might be having some lesion in their brain.
What is
Uh,
lesion? I'm a poor
Something,
motor mechanic. I'm sorry, I'm not understanding these magical terms.
uh, something, something that occupies the space in the brain,
Mm-hmm.
something that
Mm-hmm.
should not be there. All right.
Mm-hmm. Mm-hmm.
Uh, Sometimes some salts in the body can be disbalanced, and it can also lead this. Sometimes when people don't drink enough water or they
So I
don't
want
eat
to ask,
regularly.
what is the cause of this bad fitting episode which has landed him up on this artificial breathing machine? What are the causes in my son? I'm
In case
surprised that he's getting it.
I see. In case with your son, it is not quite clear at this point. We've done all the necessary investigations, and I'm pleased to say that all of them are normal. He doesn't have anything in his brain that would be causing it, and his blood tests are all fine. I think potentially you may need to speak to your son. Maybe there is something that he would like to tell you that he is not telling us, that might have caused it. Sometimes people are taking alcohol and end up having seizures, or they are being provoked.
Sorry, last sentence was interrupted slightly connection error. Please repeat last
Yeah.
sentence.
Some people might be having fits because they had taken alcohol or something
Mm-hmm.
like this. So maybe you need to speak to your son. At this point, all the investigations were normal, but we're going to be referring him to something that is called first fit clinic, and he will probably need a further investigation. At this point, he
Really,
does not
I'm not
need.
understanding. At this point, you are saying to me that everything is normal. Secondly, you're
Yes,
saying that you'll be sending him to first fits clinic so that for
yes,
the further evaluation. Thirdly,
yes.
I don't know, like he's not a doctor. How he will be knowing the cause of this fitting episode? I want to ask you exactly what you are thinking, what it can be, because let me clarify. I'm a concerned dad. And this is a pleasing news for me that there is everything is normal, but not a pleasing news for me. Because being a concerned dad, it can happen again if
I
there's no
understand.
mind.
Exactly. This is why, so we are now ruling out the most serious causes, right? Um, and sometimes we do not find any reason for this. So some people
So
who are
you mean to
having
say
fit,
that there is no reason in my son, like this is what you want to say.
at this point, we do not know the exact reason. Um, as I said, we ruled out the most important. We know for sure that there is no tumor in his brain that could be causing it. And there is no problems with the blood supply in his brain that might be causing it. And his blood tests came back as normal. Uh, and at this point, he is not requiring any treatment because it only happened once. It might not happen again ever, or it might happen, and in this case, he will need further treatment. But we need to
Mm-hmm.
do a further investigation, something that he will be having in the clinic as outpatient. Um, Sometimes, as I said, those fits are happening and we can't find the reason. Sometimes we find the reason on the further investigation. Um, Most importantly, is your son
If you
driving?
don't mind, I want to interrupt you over there. I want to ask you what further investigations you are planning for my poor son.
It is going to be another modality of scan of his head. We've done something that is called CT, and now we will need to do an MRI. This is a more detailed scan, and
So you are thinking that this MRI will might be giving some sort of more information about
it might,
diagnosis, right?
it might, but at the same time, it might not show anything. Uh, it might, it might most likely come back as normal. And another investigation, we will be recording electrical activity of his brain as well to understand if there is anything abnormal going on. Um,
Okay.
do you have any questions at this point?
No questions at all. But just being a concerned that I'm not well, that he's having
I
fitting
understand.
episode.
As I said, you probably need to speak to your son as well. Maybe there is something that he
Yeah,
will
of
want
course,
to tell you.
I will be
And
meeting
my
him.
main concern is your son driving.
Yeah, he's driving.
So you just have to be aware that at this point of time, he should not be driving. Um, he may he may be able to drive in the future, but we need to have a year since the point when his last fit happened. So if given that no fits ever happening in the future, we need to make sure that he's not
So he
driving
should
for a
not
year.
be driving the car for at least
Yes,
how many months?
12 months.
Hmm.
And if he doesn't have any fits within this 12 months period, then he's good to go. But if, let's say, he's having another fit in 3 months' time, then we will need to count from that new fit.
It means that there's a risk of the fitting episode in the future also, and this stress is
Um,
killing me.
I understand. I can reassure you that I personally do not think that there's anything going on, but I have to be on the safe side and I have to inform you that these possibilities may happen. Because, as I said, we ruled out most important, most severe causes of the fits at this point, and there is nothing wrong with him. It's just a generic follow-ups that we're doing to pretty much everybody who's presenting with fits.
Okay,
Do you have
1 minute
any other
from now?
questions?
No.
And
Mm-hmm.
do you know who your son is living with? Is he living with you or he's living on his own?
He's living with me. He's only 18 years old. Poor guy.
Okay, right, that's fine. Um, and do you know if he's watching TV frequently or attending clubs where, the flashing lights might be present?
At least I'm not sure exactly that he is
Mm.
visiting the clubs and he is, no, yeah, regarding the TV, he's not seeing it and he is more into studies. And your
Mhm.
time is up.
Okay.
Dr. Olena, overall, nice communication, nice effort, but few things really, you can say, just a second. Few things are bothering me. There is, my voice is clear.
Yes.
There is a principle, rather, what you say, ethical consideration called, just a second, called truth telling. What is truth telling? That we should always be speaking truth with the patient and the family, right?
Hmm. But I think
Now
we're now on the
you,
patient side.
yeah, you are telling, making a few statements that we don't know about the cause of the fit in this patient, or we don't know the cause exactly what is causing the fitting episode in your son. This will be going against truth telling because the
But if
statement is wrong.
patient is giving us consent to speak about everything but this thing, shouldn't we respecting the patient's wishes and not to speak about certain aspects?
That's why we're conducting this session. I'm explaining. But for now, truth telling should be followed. Your concern that the sun is stopping me is extremely valid concern. Are you getting me?
Mm-hmm.
Now, there are two fine lines. One line is that other line, are you seeing it?
Mm-hmm.
We should be in the confinement of these both. We're not crossing them. And this is not an easy job. It needs some technicalities in the communication. We should not be saying anything which is not true because they are testing it. That's why this scenario has been formulated. Secondly, we must not break sun confidentiality as the sun is requesting. Clear?
Mm-hmm.
Overall, your communication is very good, but few things need to get rectified. Now, number one, no breakage of confidentiality should be there. Number two, no false statement. Number three, if we are offering EEG or MRI, is it backed by our scenario or evidence in the scenario or not? It is also very important. Clear?
Mm-hmm.
Further investigations is logical or not. This is also very important. So scenario in the short is that the son was having some night parties, nightclub, having some drug, and after drug he's having fitting episode. Now he was intubated. Now he is well and no cause has been found. He is fully well and we are very convinced that the drug is the cause, that is ecstasy. Clear?
Mm-hmm.
Now, one thing we need to talk with the dad. Secondly, we need to formulate further plan also. We need to consider that right now we should be offering for MRI or EEG, or we should be offering some other management plan. Clear?
Yes.
Good. So this is the difficult scenario. I'm saying it even before starting. This is not easy scenario, and you have done it well, except few light mistakes. Now, first thing when we are doing the scenario is yours introduction, like you're doing, then patient's introduction. Hello, sir. Good morning. My name is Dr. SM, one of the doctor in the clinic today. Am I speaking with the dad of Mr. X, 18 years old? Yes, I am. I have already taken the permission of your son to talk with you if it is okay with you, okay with me. So these protocols should be followed. Okay, Dr. Olina?
Yes.
Then you have to, instead going ahead directly, first establish the rapport. So I hope I am not keeping you waiting too long to see me today. Or you can simply ask how you're feeling today. Then first have the idea what you have been told so far about the health condition of your son by the medical team, the treating team. So he's saying that, yeah, I was coming to hospital. I'm listening that to start Mr. talking. He was having fitting episode. It never happened. It's the very first time. So why it is happening? Why it is happening? So this is the main concern you can say. It's the main question you can say. This is the main concern told by us even when we were sitting outside the examination hall. Now we'll be starting like that. Sir, I really appreciate your knowledge about your son that he is having a fitting episode. And you are very right that he was having it last night. Let me tell you that when he presented to us, he was not in a good state. So we have immediately put him on the artificial breathing machine. So intubation or something like that is a jargon. Clear?
Yes.
Here I am pointing it out like intubation. What is intubation? And I think you said in another word also of the medical word. But in the exam, nobody will interrupt you. They are just listening to you keenly and they are just writing the feedback. So avoid jargons. You will not be speaking any medical word. So, say for example, you are tempted to speak it because we are doctors and we're using these words very commonly, these are on our tongue. So, you can simply say, sir, he was intubated. By intubated, I mean we were putting him on artificial breathing machine. You can immediately translate it. Okay. So after that, now the good news is that he has recovered. Now you have given this news. Instead of starting by yourself, try to let him absorb this news and try to see exactly what he is bringing up now. So he's bringing up that he might bring up, or you are bringing up, no problem. There is no deduction of the marks. You can bring up about the cause of the fitting episode. Say that, sir, we have done all lab workup, including sophisticated brain testing, and every test coming out to be normal. Clear?
Yes.
And according to these results, as they are normal, no sinister cause is there. Notice my words. According to results, according to imaging, according to lab test, no sinister cause is found. Is it true statement or
One
false?
statement. True.
Sorry? True
True
statement.
statement. Yeah.
This is totally true. But if I am saying I don't know the cause, it will be a false statement. Are you getting me?
Yes.
Good. So I'm saying according to test or results or lab workup or imaging, no cause has been found. So we are confident that there is no sinister or dangerous cause in your son.
So
Then what is the cause?
instead of
Sorry?
saying it's not quite clear what is the cause, we should say we did not find any cause.
In the tests,
Yes.
in the labs, in the imaging, in the sophisticated tests. Clear?
Yes.
This is totally true. Now, he's saying, I'm very stressed out. He never got any history in the family of the epilepsy. What is the cause? Now, see that he is aware of the cause. He's a surrogate. information has been given that your son has taken drugs, and he will push you to speak about it. Why? So that you will be breaking the confidentiality of the son. Now, this is the art of communication called accurate clinical communication. You'll be saying that's why your concerns are really valid to me. And of course, being a concerned dad, these concerns are very logical. Lot of time it is happening that no cause is there in the lab tests, even despite of extensive workup. Is it true statement or false statement?
True.
True statement. I'm not telling any lie.
No.
So he's saying that what we should be doing now. Say that, sir, yes, this is the thing which I want to talk about. Lot of time it is happening that the teenagers are passing through some stress, or they are having some sort of issues in the house, in the home, or in the working environment, sometime in the as a student life. So I really suggest you that you should be sitting with him and having a good open communication with him.
Mm-hmm.
Maybe he is speaking something about his condition. Might be this is giving us some, it might be it is giving some clue exactly what he requires. Clear?
Yes.
Good. Now, after you have completed it, so you are giving also logic that the teenagers require this discussion frequently. And you should be closer to your kids, and you should not be having any sort of any gaps between the kids. So after that, we have finished this scenario maximum almost 80%. Now, the next challenge over there will be the further, you can say, things, the further workup. Oh, sorry, the further plan. Further plan, you are very right. We are restricting the driving not for 12 months, rather for 6 months. Clear?
Is it? Mm-hmm.
Sorry? Yeah, 6 months.
Yeah, I was pretty sure it's 12 months.
Are you sure?
I think I am sure.
If you are sure, then I should be checking it.
I think
Uh,
in the UK it's 12 months after the first
I
after
think
the
in the
last episode.
UK, yeah, I think in the UK, according to NHS protocols, it is 6 months. But if I am wrong, I am really never minding it if somebody is correcting. So kindly do update me. Rather, let's see what other candidates are saying in the Zoom chat box. Let's take their help. But for me, I think it is 6 months. So anybody, please let us know in the Zoom chat box. Is
Yes, it
six
says
months
you
or
should
12
not
months?
drive for at least 1 year after being seizure free.
Up till now, I am getting most of the replies.
Epilepsy Society says 6 months.
6 months. Okay, okay, no problem. We will be
Uh,
confirming it then. Because one candidate is saying 12 months and 6 or 7 replies I'm getting, they're saying 6 months. But I think it should be confirmed, no problem at all. It should be, checked or rechecked. But what I'm remembering is that it's 6 months of subscription after first episode. Okay, no problem. It will be checked. Okay, now main thing which I want to focus over there, which is more, or you can say, a more difficult thing. So the thing over there is that now we need to restrict driving according to whatever the guideline is. Then we have to go for
oh,
some follow-ups.
sorry, I've
So
got to Gov.uk. So basically, Gov.uk says if it's proven epilepsy, then it is 12 months since the date of recent seizure. And
mhm.
if it is first unprovoked epileptic seizure slash isolated seizure, then it is 6 months from the date of the seizure, or 12 months if there is an underlying cause.
So 6 months.
Yeah, so if in case with this boy, it's 6 months, but if we prove it like
Yeah,
that it's epilepsy and
epilepsy,
it's
then 12.
recurrent, then it's
Yes.
12, yes.
Yes, this
Oh,
is
both
also
both of
coming
us
in
are
my
right.
mind. Okay, no problem at all. Because these little things can be checked anytime.
Mm-hmm.
Main focus over there is for the communication, which is the more harder part. So it is 6 months restriction in this case for driving. Okay. Now, next step after driving restriction is something called follow-ups. So you have to call the patient for the follow-up, say that we are quite concerned about his condition and we want to follow him up in our OPDs. Now, where you will be following up, of course, towards the mood doctors, of course, towards the
Course,
brain
the
doctor,
clinic.
neurologist. So why? Because this guy is taking some medication, some drugs. We can simply say that I will highly suggest you that you should be following up your son in our OPDs, or he should follow up in our OPDs, mood OPDs, and brain OPDs. Now, let's get ahead. Social history is very important in this case. So, social history, you can ask directly how is the social support of the son at home, who is taking care of him at home, who is more closer to him, or any stressors, or ever you got any evidence of alcohol or smoking, a journal history. Check this question. Then, in the end, you should be providing a detailed leaflets, brochures, the addresses to the dad so that he should be well aware about the driving restrictions about this complete communication. Clear?
Mm-hmm.
Good. So this is all about this case. So why I have chosen this case, and we have done it before also, I believe. The reason is that this is a difficult communication and always posing a challenge because things are not, you can say, straightforward. At one point, we have to respect the patient confidentiality, and at the other point, we must not speak any wrong or false statement. Now, what I want to say is that clinical communication is an art. We should be knowing all the ethical principles, the legal principles, of course, the medical issues in the scenario. Of course, we should be knowing exactly how to communicate crystal clearly to the patient, to the surrogate. And we must remain in the confinement of our scenario. If we are speaking anything wrongly, say for example, I'm saying that, yeah, your son is, I'm sorry, I'm trying to tell you, your son is taking drugs, I will lose all my marks. If I'm saying that no, he's not taking any drug and he is very well, and I hope that these seasons will never appear again, it will also be a wrong statement. So I need to remain in between two limits. Clear?
Mm-hmm.
Good. Any questions, any queries, any confusions, any problems by any candidate? If anybody wants to ask any questions about these scenarios, please use the raise hand option to come forward. I will be more than happy to answer you. Any questions, any queries? Okay. If no questions, we will be ending this session over there. Thank you all. Thanks to all of you for your participation, your listening, and your interest. Inshallah, I hope I will be able to conduct another session also next weekend. With this, we are
Thank you.
concluding our session. Welcome, welcome. Have a good night. Goodbye.